from the crash revision for the SCA. Let's look at the management of stroke, TIA, under stroke. The guideline for management of stroke and TIA is obviously from Gloucestershire Hospital, snipped from Gloucestershire Hospital. So let's have a look. So consider alternative diagnosis, see guidelines document, So possible stroke or TIA. Because if there's complete resolution of focal neurology, then if yes, then it's a TIA. If no, so it's ongoing focal neurology, then it's you make a clinical diagnosis of stroke. So if it's TIA, they're still using the old one. If you calculate ABCD score, shouldn't NICE guidelines say we should use ABCD score once you face suspected TIA? And the question is, you need to be thinking about secondary prevention. So you need to be prescribing aspirin. I'm not even sure they have. What's there? Let's have a look at this. Gloucestershire management. Okay, yeah. So let's jump to their management. We're not doing the ABCD score. So it says here, start secondary prevention. Obviously, person already has a TIA, which means person already has cardiovascular risk. So the next thing is you want to prevent further TIAs, eventual occurrence of stroke. So what you need now is secondary prevention. So you start aspirin 300 milligrams once a day, or clopidogrel 300 milligrams. Start dose, single dose. And then aspirin if appropriate. If currently on anti-platelet agents, I feel like let's just move more. Let's move to this one actually. Yeah, let's use this. So secondary stroke prevention or secondary TIA prevention, of course, lifestyle advice, so low salt in the diet, encourage exercise, healthy diets, cut down alcohol to less than 40 units a week, weight reduction, exercise, smoking cessation, refer to smoking cessation clinic, and consider nicotine replacement therapy prescription, which can be the gum, the patches, the inhalators, nicotine replacement therapy. Issue supporting written material and contact numbers for the Stroke Association peer group, peer support, information and advice service. Now, if the person has hypertension, you need to control their blood pressure. They are diabetic, you need to control, make sure their diabetes is well controlled. So do not commence treatment until the neurological deficit has fully resolved or until 2 weeks after the stroke, whichever comes first. So this is stroke. Treat with thiazide-like diuretic in first instance. So before you start, this is when if it's like an acute stroke, you have to wait before you start blood pressure tablets because you don't want to lower the blood pressure, thereby compromising cerebral perfusion. But you can obviously use diuretics at that stage. Add ACE inhibitor if target blood pressure is not achieved. Use a long-acting calcium channel blocker as third line, like amlodipine. If target blood pressure is not achieved, aim to lower the blood pressure to less than 130/80 or by 10%, whichever results in the lower blood pressure level. Note, after stroke or TIA, normotensive patients benefit as much as hypertensive patients from blood pressure reduction. Such that the patient's blood pressure, for instance, is 140/90 and the person has had a TIA or a stroke, then we probably still need to be targeting a blood pressure that is less than 130/80 as long as they're not having hypotensive symptoms with that. Now, we need to be thinking as part of our secondary stroke or TIA prevention, we need to be thinking about statins. So treat all patients with a low cholesterol diet plus atorvastatin. So we should be starting atorvastatin at least 20 milligrams once a day. We could always increase that to 40 and sometimes even 80 milligrams once a day. Increase as necessary to achieve targets. Now use antiplatelets use of antiplatelets and anticoagulants. Of course, if the person has atrial fibrillation and has had a TIA, if the person was previously not on anticoagulation, you need to be starting anticoagulation immediately. Of course, to checking their orbit or has blood score to make sure they're not at significant risk of bleeding. So is this atrial fibrillation present, including paroxysmal AF? If no, then if yes, anticoagulated warfarin or the novel anticoagulant drugs, also control rate with digoxin or verapamil, the or beta blocker. So the anticoagulant treatment below. If the patient doesn't have AF, then or they've had a TIA, or an ischemic stroke, give clopidogrel 75 milligram daily. If intolerant of clopidogrel, then use aspirin 75 milligram daily for dipyridamole. So this is for secondary prevention. But in terms of TIA management, we should go back to this one. I'm not sure if they actually have it there, if they wrote it in the right way. I want a NICE guideline, actually. Because what NICE guideline essentially is saying is ICKS. Let me go to the top. Let's go into NICE CKS and revise that. TIA. Secondary prevention. Okay, so let's look at this. So how should I manage a person who suspected TIA? So for people who have had suspected TIA within 7 days, offer aspirin 300 milligram immediately, unless contraindicated. Give a protein pump inhibitor to anyone with dyspepsia or shortage of aspirin use. If aspirin is contraindicated, discuss management urgently with this specialist team. Advise people already taking low dose aspirin to continue on that low dose. So if the patient is already on 75 milligram aspirin for secondary prevention of cardiovascular disease. Don't increase to, don't give them extra 225. Just let them carry on with the 75 milligram. Refer the person for specialist assessment and investigation to be seen within 24 hours of onset of symptoms. People with bleeding disorder or taking an anticoagulant should have an urgent CT scan to exclude hemorrhage. Do not use the scoring system such as ABCD2 to assess risk of subsequent stroke or to inform urgency. So once a person had a TIA or a stroke, there's risk of having a further TIA or stroke, so you don't need to do an ABCD score anymore. Just treat them as high risk for a stroke. Be aware that a person may have ongoing focal neurological deficits despite a negative fast. So they might be fasting the face, speech test and all that. Because some people can have stroke involving sensory deficits without having any significant motor deficits. So even if they're fast negative or they have ongoing neurology, you treat them as an acute stroke. People who have had suspected TIA more than 7 days ago refer for specialist assessment as soon as possible. Within 7 days, they should be seen within 7 days. And obviously, you can also use secondary stroke prevention because there's still a risk of having a stroke before they get to be seen at the TIA clinic. So you need to be starting them on aspirin at that stage. Probably be just prescribing the low dose 75 milligram aspirin. And obviously, if they have AF at that stage, you also want to be checking their chat VASC again and like their orbit score or has bled and starting them on anticoagulation even before they get to be seen by the specialist at the TIA clinic. If all people who suspect that TIA and the family members information of recognition of stroke and TIA, and if it happens again, you should call 999 immediately because obviously at that stage, you never can tell them I have a worse, neurological outcome if it happens again. Let's go back to where this is the one we looked at secondary prevention. Yeah. Okay, so that's a good revision for stroke. Let's look at giant cell arteritis. So assessment and management of suspected GCA, giant cell arteritis, also called temporal arteritis. These are sniffs from Buckinghamshire, okay, NHS Trust. Um, so the giant GCA is a medical emergency requiring prompt assessment and immediate steroid treatment in order to prevent irreversible loss of vision, because it can cause irreversible blindness. Suspected GCA. So commence or once you suspect GCA from a clinical assessment, you need to be starting them on steroid even before GCA is ruled in or ruled out. Commence oral steroid therapy. Visual symptoms, or if they have ischemic symptoms, which are visual symptoms, loss of vision, you know, if they have jaw claudication, start them on 60 milligrams of prednisolone once a day. They have no ischemic symptoms, so they have headache, but they don't have jaw claudication, they're not having a loss of blood vision or any other visual symptoms. Then you start them on prednisolone 40 milligrams, so a lower dose, 40 milligrams once a day. And if they have visual symptoms, you need to be referring them immediately to the ophthalmology team on call. They don't have visual symptoms on job classification. They don't have visual symptoms, obviously, you need to be referring them urgently to rheumatology. They should be seen within 72 hours, within 3 days. No. Prescribe aspirin 75 milligram. No, that's a wrong information. I'm not sure why Buckinghamshire just has that on there. So aspirin is not routinely prescribed. To be honest, in suspected GC, the most important thing is prednisolone or methylprednisolone IV. If they've got visual symptoms, you should be given that in hospital. Because you need a full blood count, your need is LFT, the most important thing is CRP and ASR within 24 hours. Do not wait for the results. Start them on steroid. So visual symptoms, if you immediate referrals, eye casualty, contact the on-call ophthalmology registrar, blah, blah, blah. If you have active visual symptoms, then ophthalmology will give intravenous methylprednisolone, arrange temporal artery biopsy by ophthalmology and refer urgently. So ophthalmology suspect that if there are no visual symptoms, you refer urgently to rheumatology and they should be seen ideally within 7 to 3 working days. What rheumatology will do is rheumatology will really very likely do a temporal artery, superficial temporal artery biopsy to confirm the presence of temporal arteritis. They could also do an ultrasound of the temporal artery, obviously. This needs to, so ultrasound needs to occur within 7 days of starting steroid. Rheumatology arrange temporal artery biopsy if indicated in order to increase the chances of a positive result. Temporal artery biopsy tab should be performed within 7 days. The ultrasound should be performed within 7 days. Starting steroids, you're gonna get a more reliable result. Same as the biopsy within 7 days of starting steroid, what can remain positive for 6 weeks. Complete temporal artery biopsy referral form, blah, blah, blah. So CRP is more in most cases of GCA or temporal CRP will be raised, but a normal CRP does not exclude the presence of a GCA. So that's something to be aware of. And then you have to telling these patients that very likely GCA is confirmed, they will be on steroid for up to 1 to 2 years. So they'll be on steroid as soon as the symptoms settle, then you will now taper their steroid down to the lowest tolerable dose that's keeping their symptoms stable, keeping them symptom free. And then they usually remain on that dose for say a year. And then you now slowly wean them off that steroid. Because you start to do it slowly to prevent Addisonian crisis. Let's look at varicella exposure and pregnancy. So chickenpox exposure and pregnancy. The woman is pregnant and she's been exposed to varicella. What do we do? Because it's something that obviously can come out in the SCA. Something that can come out in the SCA. How do we manage that? So algorithm for management of varicella zoster contacts in pregnancy. So varicella zoster contacts, clarify significance of the contacts. And how do you do that? The significance of the contact is maybe how long, how close was this woman, pregnant woman, to the person who has chickenpox, how long, that contact lasts, what exactly was happening, was it a direct skin contact, were they close, like a meter close, were they close, and in the same place was 30 minutes, was a significant contact essentially. Now, if the woman has had a past history of chickenpox, she has a definite clear history of chickenpox in the past, then no action is needed. Reassure her, return to normal antenatal care. Of course, you have to safety net that if she develops symptoms of chickenpox, which could include things like if she develops a temperature, start feeling hot and cold, she develops a rash, she needs to let you know or let her midwife know immediately. But she's very much, there's a high likelihood that she's protected if she's had chickenpox in the past. If she's not sure, if you hear that she's had chickenpox in the past, or if she had a definite history of not having chickenpox in the past, then you need to be checking her varicella immunoglobulin level. And that varicella immunoglobulin level result needs to come back to you, I think, within 48 hours. So the lab usually sends the result back quite quickly. So check the blood varicella immunoglobulin level. If the varicella immunoglobulin level is not present, which means if it's low or absent, then you need to be giving her the varicella immunoglobulin injection. If she has a high titer of varicella immunoglobulin in her blood, then she doesn't need any varicella immunoglobulin, varicella zoster immunoglobulin. If a woman presents with chickenpox, if she has chickenpox, then she needs to avoid contact with potentially susceptible individuals like neonates, other pregnant women, elderly people. Symptomatic treatment and hygiene should be advised. So hand washing, if she has a cough, obviously, use of a handkerchief or something. If the woman presents less than 24 hours of the appearance of the rash, and she's more than 20 weeks of gestation, prescribe aceclidine. The woman presents less than 24 hours of the appearance of the rash, and she's less than 20 weeks, consider aceclidine. Avoid delivery of the baby until at least 7 days since the rash appeared. This thing is wrong. I don't think this is right. If this one is exposed and her varicella immunoglobulin level is low, it means she's not protected. What you need to do is to arrange to give her the varicella immunoglobulin. That's what should be done. I don't need that because you don't need to treat. She hasn't got symptoms of chickenpox. There's really no need. So this algorithm here is wrong. I think there's really no need at that point to be giving her a cycle version. You should be giving it varicella. So if the woman develops, you give her the varicella immunoglobulin, so that's what should be there. If she then goes on to develop chickenpox symptoms, then you manage her as chickenpox, and the patient with chickenpox with a cyclovir. Obviously, you need to be getting advice as GP, you need to be speaking with the microbiologist, even with the obstetrician to get advice on whether they will want to treat her with a cyclovir. Very likely she'll be treated anyway. If she goes on to develop severe infection, so woman who develops severe infection women who develop and women at high risk of complicated chickenpox should be referred to the hospital. Because of course, chickenpox is a viral infection. It can cause viral meningitis, encephalitis, and it can also cause severe pneumonia in the mom. And if she goes on to the severe version, she might need intravenous acyclovir to be given. So infection less than 28 weeks of gestation. So inform women that infection less than 28 weeks of gestation has a small risk of fetal varicella syndrome. Yeah, so because I saw a conflicting information. That, yeah, this one says women that are less than 28 weeks gestation have a small risk of, the baby has a small risk of developing fetal varicella syndrome or congenital varicella syndrome. And then obviously if she develops chickenpox more than 36 weeks gestation, then that's when the highest risk. So, but then let's look at this. Varicella syndrome. Gestational age. The risk here, the risk of those with of fetal varicella syndrome before 18 weeks, blah, 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 is delivered. The incidence of fetal varicella syndrome is less than 1% in the first 12 weeks and around 2% between blah, blah, blah. Let's have a look at this one. This is nice guidance, right? Implications of the fetus. Infection of varicella zoster during the first 28 days can lead to intrauterine infection and fetal varicella syndrome, as congenital varicella syndrome, which characterize one of the following. The incidence of fetal varicella syndrome is less than 1% in the first 12 weeks, around 2% between 12, 13, and 20 weeks of pregnancy. Cases of fetal varicella syndrome have also been reported in women between 20 and 28 weeks of gestation, indicating that there's a small risk of fetal varicella syndrome when there was after 20 weeks. So the risk of fetal damage is likely to be lower than fetal varicella syndrome occurring in the first 20 weeks. The risk of fetal damage is likely to be lower than fetal. So fetal varicella syndrome is more common in women that are less, when the pregnancy is less than 28 weeks gestation. So pregnancy less than 28 weeks gestation is when there's a higher. So the risk, overall risk is 1%, is 1 to 2%, but most of that 1 to 2% risk happens when the pregnancy is less than 28 weeks of gestation. That's what's, and if the woman, yeah. The case fatality rate of pregnant women varies from 0 to 14%. Okay. So less than 28 weeks. That's when you have the highest risk, but that risk is still small. Still small, it's about 1%, less than 1 to 2% develop fetal varicella syndrome. Refer to a fetal medicine specialist. Refer to a fetal medicine specialist at 16 to 20 weeks or 5 weeks after infection. Amniocentesis to detect varicella DNA may be considered. Okay, so it's quite, in the ST, I'm just imagining, of course, if a woman comes to you to discuss this kind of thing, to find out, how the exposure happened, if they've confirmed the diagnosis of chickenpox in the person that she thinks, has chickenpox and she's been exposed to, when the exposure happened today or how many days ago, has she got any symptoms of chickenpox? Has she got chickenpox in the past? Is she aware of any previous history of chickenpox? And things like that. She had the test in the past, first pregnancy, just ask her about open questions. What she worried about. She might tell you that she's worried that her baby might be deformed and things like that, or what she's hoping for that you would do for her. You might say, well, I need some chicken pox tablet that she read about this medication called cyclovir and things like that, or she wants to get tested, or she'll tell you what she's hoping for. And then you need to educate her on the fact that most of the risk is actually on the mom. The risk of the baby being harmed is actually a small risk, 1 to 2%. And that risk is even much less after 28 weeks of pregnancy. It's something that we need to be on, just in case it comes out in the exam. And let's look at Bell's policy management here. So management of Bell's policy, let's look at that. So for Bell's policy, the treatment, so Bell's policy is usually viral, viral infection affecting the facial nerve, causing the lower motor neuron lesion of facial nerve. So corticosteroids can be given, usually given if onset within 7 hours of onset. You can start prednisolone. So 60 milligrams of prednisolone, just a high dose daily you give that for 1 week. And then you may consider tapering it for days, about 8 to 10 days. The number needed to treat 1 in 11 So out of 11 people that have Bell's palsy, if 11 of them are giving prednisolone, one person will recover from it to complete recovery. Now, it's controversial. There's a controversial benefit of antiviral medication like acyclovir or valacyclovir. At most risk difference of 7%. American Academy of Neurology, JAMA, blah, blah, blah. For Cochrane cases such as grade 4, so Cochrane, if you know antivirus indicator, acyclovir for 1 week, also prescribe corticosteroids. So the bottom line is that corticosteroids are the main thing that you usually prescribe for about a week, and then you start tapering the dose. And it's controversial as to whether you need to be prescribing antiviral, or first you can speak with the neurologist to see. You can start them on antiviral, give them a week course of antiviral. You probably not lose much if you do that, as long as they don't have the real bad side effects from it. And the most important thing in these Bell's palsy is care of the eye to prevent exposure keratitis, because if you have lower motor neuron palsy or the infection on that side, the eye wouldn't be closing well. So you need to tell them to tape their eyes at night. You need to prescribe them artificial tears to keep the eye well lubricated. They need to avoid drops, as wear glasses to protect the eyes from foreign body. Tape the eye at night so it doesn't get exposed and dry in develop keratitis and into blindness. Artificial tears in daytime lubricating eye ointment at night to prevent corneal drying and exposure. Tape the eyelids shut while asleep. Yep. So that's essentially what you need in Bell's palsy. Let's look at restless leg syndrome. Let's go over the restless leg syndrome. We just quickly tick these things. Let's quickly look at restless leg syndrome. So restless leg syndrome can be primary, secondary. So primary or idiopathic restless leg syndrome, in most of the patients, the etiology of restless leg syndrome is unknown. A positive family history is seen in about 50% of patients, indicating a genetic predisposition. An early age of onset, before 45 years of age, observing patients with a family history. Now, secondary cases of restless leg syndrome. 3 major reversible causes of secondary restless leg syndrome are pregnancy, iron deficiency, and end-stage renal disease. So end-stage renal disease, so you'll be checking kidney function, checking the ferritin levels, of course, full blood counts, and pregnancy can cause secondary restless leg syndrome. Other associated conditions are things like folic acid deficiency, vitamin B12 deficiency, peripheral neuropathy, for instance, alcoholopathy, peripheral neuropathy, Parkinson's disease, fibromyalgia, rheumatoid arthritis, diabetes mellitus, cause restless leg syndrome. And there's some medications that can be associated with restless leg syndrome. So medications like antidopaminergic agents, metoclopramide, antipsychotic medications, antidepressants, serotonin, SSRIs, bicyclic antidepressants, amitriptyline, lithium, antihistamines can cause secondary restless leg syndrome. Now, how do we treat restless leg syndrome? Obviously, this is a secondary restless leg syndrome. It's about treating the cause, the identifiable cause. So the following medications can be used in management of restless leg syndrome. So dopamine agonists. Dopamine agonists like cabergoline, pegolide, pramipexole, propinerol, drug of choice for patients with daily symptoms. So the dopamine agonists like cabergoline and pegolide, these are the ones that are usually used for hyperprolactinemia in the galactoria. Less preferred due to side effects. Most times you use pramipexole. Levodopa can be used in patients who are intolerant to dopamine agonists. It provides relief in intermittent symptoms, can be used as a prophylactic drug. So levodopa is typically used in treatment of Parkinson's disease. Yeah, thinking of restless leg syndrome. Not really seeing patients on levodopa for restless leg syndrome. Yeah, pramipexole more commonly used. Antiepileptic medications like gabapentin can be useful in patients with coexisting neuropathic pain or hemodialysis patients. Opioids, weak opioids like codeine tramadol can be used for intermittently or daily for painful restless leg syndrome. Benzodiazepines like clonazepam used intermittently in sleep onset insomnia caused by restless leg syndrome. Imipramine, which is an tricyclic antidepressant. Imipramine can be used before bedtime, before retiring, 30 minutes before retiring. So 30 minutes before going to bed. Other medications that can be used are things like clonidine, carbamazepine. It's about telling patients that the good thing is that there are many medications that can be tried to help with your symptoms. So other things that also help with exercise, graded exercises, relaxation exercises, cutting down on alcohol intake, cutting down on caffeinated and fizzy drinks, and things like that. CBT can also be helpful if it's really affecting the patient, especially if causing depression and anxiety. If causing insomnia, you could be thinking of insomnia, CBT for insomnia, of course. If you're trying some benzodiazepines, okay, it's a big one to help as well. It's about a holistic approach towards managing the patient. So it's all about the holistic approach. That IBS. Let's look at IBS management. So IBS is irritable bowel syndrome, which of course is different from IBD, which is inflammatory bowel disease. So IBS essentially is a diagnosis of exclusion. Patients with IBS typically present with symptoms of colicky abdominal pain, abdominal cramps that happen shortly after meals, and then they could also have this fecal urgency that happens shortly after meals, few minutes after eating. They have the need to rush to the toilet with crampy abdominal pain or discomfort, and then as soon as they've had the bowel motion, that pain usually relieves. So typically, they can also have constipation. So you can have constipation predominant, you have diarrhea predominant, IBS. That's just in a nutshell. So it's actually essentially a diagnosis of exclusion. The patients have IBS kind of symptoms, you want to do some blood tests. You want to probably be ruling out IBD as well, so you're considering whether it's appropriate to be fecal calprotectin, to rule out inflammatory bowel disease. You also probably want to use screening for celiac disease using your TTG, tissue transglutaminase antibody test to make sure you haven't got celiac disease. So IBS management pathway for adults with lower GI symptoms under 50 years of age using calprotectin. You can see IBS. So inclusion criteria: age 18 to 50 years old, symptoms consistent to IBS, no red flag symptoms, and cancer not suspected, no more routine bloods and stool culture. So you also probably doing stool culture to make sure there's no infective cause. Now, if fecal calprotectin is less than 100, IBS is 98% likely, and of course, very unlikely to have IBD if fecal calprotectin is low. Give a clear explanation and patient-centered discussion of IBS. Now, first line dietary and lifestyle advice. So you need to be telling them to increase their fluid intake, high fiber diet as well, healthy diets, using healthy diets, yeah. Lifestyle advice, cigarette smoking cessation, cut down on alcohol, healthy diets, and things like that. Exercise can help improve bowel health as well. Screen for depression, anxiety, first line medication treatment, follow up by primary care in 6 weeks. Now, if the symptoms have improved, monitor and primary care. Symptoms are ongoing and fecal calprotectin less than 50, IBS 99% likely, consider specialist IBS dietetic referrals. You can refer to the dietitians. The second line dietary advice: check calprotectin is not done previously prior to referral, if not done, to check it. And diets, nutrition, lifestyle assessment, elimination of diets if deemed appropriate. So another thing that is very important this thing is symptom diary. There are certain foods, certain diets that will be triggering the patient's IBS flares or symptoms. So we need to encourage them to keep a symptom diary to find out certain things that they eat or drink that will cause them to have these symptoms and they should avoid them. So patients follow diet and return for follow-up 8 weeks later. There is diet success. Patients talks through how to introduce foods. Patients can be discharged, letter sent to blah blah blah. If that is unsuccessful with refractory symptoms, further GP management options, trial or second line medical treatment like amitriptyline, SSRIs, cholestyramine kind of tried, of course, or that second line. So if we go back here, if we go back here, so first line dietary advice. So if symptoms ongoing, fecal calprotectin greater than 50 but less than 100. IBS is 1% likely, but in secondary care. So I'm not sure where they've not really mentioned some medications that typically used in IBS medications like mepefermin, which is an antimuscarinic medication that also relax the bowel, smooth muscles of the intestine, preventing those colonic and intestinal colics. So mepefermin, which can be taken regularly, usually I think usually 3 times a day in weeks before meals, taking before meals. Is that right? Yeah, and so mepefermin, so it's an antimuscarinic agent, and then obviously buscopan and hyoscine can also be used in management of IBS kind of symptoms. If the patient is having constipation predominant, obviously using laxatives to treat the constipation. If they're having diarrhea predominant, probably will constitute some PRN or pyramide as well. If you're having diarrhea episodes. But if the fecal calprotectin is 100 or more, we have to repeat the fecal calprotectin. If your symptomatology is fitting, that of IBS, probably repeat it. If it comes back less than 100, then it's more likely to be IBS. If it comes back still 100 or above, then it's more likely to be an IBD, inflammatory bowel disease. So IBD, that's 3% likely. So you don't think, oh, could this patient actually be having IBD and not IBS? I say you can repeat fecal calprotectin. So at what point do we stop repeating this fecal calprotectin? We're just trying to save resources. If we're thinking, oh, there's possibility of IBD, I think the best thing is to refer that patient to gastroenterology at that stage to consider doing a colonoscopy. Yeah, as you in secondary care. So if the fecal calprotectin is 250 or more, there's a 46% likelihood that it's IBD, inflammatory, so Crohn's or ulcerative colitis. At that point, you need to refer urgent referral to gastroenterology. It's worth knowing. Let's see, there's something else on IBS. So IBS flow charts. It's not similar. Yeah, fecal calprotectin is similar to some very similar to what we've said. Let's just have a look at this. So IBS diagnostic flow charts for adults under 50 years of age, history and examination in primary care, age less than 50 with the following symptoms for at least 3 months: abdominal pain, bloating, changing bowel habits. Well, the person is like 47. The person is 47, hasn't had IBS kind of symptoms before. He's having abdominal pain, bloating, changing. You have to be checking, you have to be doing a Q fit as well. The quantitative fecal immunochemical test, check for blood. And if it's that's what that. You can't just make it down. That's why IBS is against substitution. Now, you just ask any red flag, any unintentional weight loss, any unexplained rectal bleeding, any family history of bowel or ovarian cancer, any abdominal mass, any rectal mass, iron deficiency, any nocturnal diarrhea. If cancer is suspected, obviously be doing your Q fits to help guide your diagnosis as well. If cancer is not suspected, then a positive diagnosis of IBS should be considered if the person has recurrent abdominal pain, an average of at least 1 day a week in the last 3 months. To be honest, I wouldn't feel comfortable with a patient who is 48, 49 having these kind of symptoms, if they've not been previously known to have IBS, I'll probably want to make sure I completely rule out the bowel cancer before I make that diagnosis of IBS. This is usually accompanied by at least 2 weeks following pain related to defecation associated with a change in bowel habits associated with change in stool form. Common symptoms include abdominal bloating and distension, other features such as lethargy, nausea, depression, anxiety, fibromyalgia, backache, other symptoms are common in people with IBS. May be used to support the diagnosis. Do a full blood count, CRP, celiac serology. If abnormal, refer secondary care. If normal, it's more likely IBS is not. So positive diagnosis of IBS. Manage as per IBS management pathway parameter. If uncertainty at the diagnosis is it IBS or IBD, then you probably need to verify into. If you're thinking there's a possibility of IBD, then you check the fecal calprotectin. Organize fecal calprotectin, ensure off NSAIDs or PPI for 2 weeks. You want to make sure off NSAIDs because you want to make sure the NSAIDs are not causing mucosal bleeding, which should give you a false positive fecal calprotectin. You want to be off PPI to make sure the PPI is not protecting the bowels, might give you a falsely low calprotectin. So you want to be off NSAIDs or PPI for 2 weeks before you do fecal calprotectin, and even before you do the Q-fit as well, same thing, off NSAIDs and PPI for 2 weeks. Calprotectin, if it's possible anyway, the person has very worrying dyspepsia and cannot stay off. You are probably using the antacids. Calprotectin less than 100, more likely to be IBS. Calprotectin 100 to 250 repeated in 2 weeks. If it comes back less than 100, IBS more likely. If it comes back still greater than 100, you're not thinking IBD. If it comes back greater than 250, you're thinking strongly of IBD now. Ensure stool culture sense, refer to gastroenterology urgently highlighting suspected IBD pathway. So yeah, so it's in before this. So that's it. That's how maybe IBS is managed. And then we look at smoking cessation guidelines. Let's look at that. So for smoking cessation, it says tell people who smoke that a range of interventions is available to help them smoke. Because you want to find out if the person has thought about smoking, what are their thoughts about smoking, giving up smoking, have they tried it before? Is it something they thought about? You know, if they thought about it, it's like you're like, okay, have they planned on when they would like to stop, and what are the reasons why they've considered smoking cessation or stopping smoking? You know, what are their motives? What's encouraging them? What factors encouraging them to want to quit smoking? Hear from them. And then support them. But yes, smoking cessation is usually good, as smoking has been shown to be linked to a lot of health problems like lung problems and so many cancers. So usually I encourage everyone to actually consider stopping smoking, and there are services and medications and several support available to help you go through that process. Ensure the following are accessible to adults who smoke: behavioral interventions. Very brief advice. So medically licensed medications like varenicline, bupropion, nicotine replacement therapy, and can be used. In November 2021, varenicline was unavailable in the UK. I've seen patients that said they previously used varenicline, but at some point it became unavailable and they just couldn't get it anymore. Consider nicotine replacement for young people aged 12 and over who are smoking and dependent behavioral support. Do not offer varenicline or bupropion to people who are under 18 years. Offer behavioral support to people who smoke, regardless of which option they choose to access it. Discuss with people which options to use to stop smoking, taking into account their preferences, health, and social circumstances. Any medications they are taking, any contraindications, and potential for adverse effects. Their previous experience of smoking, of stopping smoking, their previous experience of stop smoking aids. If they tried to stop smoking before, was the experience, why do they think they they were not successful, why they resume smoking, what happened, did they lose their job, something life becomes stressful, you know. A lot of people stop smoking, but when they become so stressed, they go back to smoking to try to cope with stress. I also see the advice in the recommendation of medicinally licensed products. Consider nicotine replacement therapy for young people aged 12 and over who are smoking. Okay. They still do not offer for any clients those who are under 18. It's like a duplication. That's, yeah. Advise people that the options that are less likely to, that the options that are less likely to, when combined with behavioral options, are short acting. There's something, there's something cut out. There's something cut out. So let's go. Let me open it. Our formulary looks different now. Oh, really? You've changed the way the formulary looks. So we can use bupropion. Yeah, nicotine replacement therapy. These are different options shown in an RT. Varenicline, previously. A supply disruption and last 2021. Suicidal behavior and varenicline. Parents should be advised to continue treatment as front medical advice if they develop agitation, depression, suicidal thoughts, varenicline, and be associated with that. Just the history of psychiatric illness should be monitored closely while taking varenicline because it's the Champix here, that's the trade name. A lot of patients have told me there's no date of there's no date for a supply of Champix availability of varenicline for until further notice. Wow. No new patient should be initiated on Champix varenicline products like that. Varenicline is recommended within its license indications as options for smokers who have expressed a desire to be smoking. Varenicline should normally be prescribed only as part of a program of behavioral support. Okay. Okay. Yeah, I think we should take a break. I'll continue later. Let's take a short break.